The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Now, here's your host, Eric Bauer.
We left off talking about the different blood trials. We talked about the proper trial. We talked about the prompt trial. And again, we need to think about permissive hypotension, only giving enough volume to maintain a perfusing pressure, and that's a MAP of 65 in a non-traumatic brain injury patient. And I've said that multiple times, and I think we forget about that again, remember that our cerebral perfusion pressure has to be at least 70 to perfuse our brain. And that means that we have to have a MAP blood pressure. If we look and take a patient with a normal ICP, our normal ICP range is 0 to 15, 0 to 20. You talk to some neurosurgeons, and they say in a traumatic brain injury patient to always estimate about 30. And so if you did that, we would be way above 100 systolic to try to achieve a cerebral perfusion pressure. But we know a cerebral perfusion pressure is 70. We would have to have a MAP of at least 85 because it's our MAP minus our ICP. And we just use that high end of normal, which is 15, subtract that from our MAP, and as long as we can achieve 70, that is our goal in a traumatic brain injury patient. So it really does add a different element to our care for a trauma patient with an associated traumatic brain injury. And that's something we got to really focus on, because if we deliver our patient and we think about we're maintaining that MAP of 60 to 65, they've got a traumatic brain injury patient, traumatic brain injury, and we deliver them and we think we're doing the right thing by permissive hypotension, we've basically maintain a cerebral perfusion pressure during our transport of 50. And that's just with an ICP of a high end, which it could be higher, right? And anything in the 50s, we're infarcting the brain. So that really does add a big element that we have to consider. And so if we kind of recap our case, remember we have a 28-year-old, 100-kilo male hit by a car. We're transferring them to a level 1 trauma center. Current blood pressure is 88/62, pulse of 130, and tidal CO2 of 22. Remember, we had a shock index identified of 1.4. We had a pulse, remember, that was tachycardic. That's very ominous. Patient is intubated, 7.5 ET tube. Breath sounds were absent on the left, coarse on the right. We discussed, actually, maybe this tube is a little too deep. Maybe we should just decompress. I think those are all valid concerns and treatment options. And then remember, we were in a mixed disturbance on our blood gas. We had a low pH, acidotic pH of 7.21, CO2 of 47, bicarb of 16, and we did have a base deficit of -9. On our labs, the two big key things that I want to focus on is our mag and our calcium are low, and we're going to really hit on that here in the next 30 minutes. So if we dive back into our case and we look at what are some things that we have to worry about when we give packed red blood cells.
So, packed red blood cells contain all of our oxygen carrying capacity, but it's locked up.
Yeah.
It's locked up. The preservative in packed red blood cells is citrate. Citrate binds to 2,3-DPG, which is seen as the crowbar that unlocks that hemoglobin molecule so that our oxygen can bind to it. So that's in the preservative that keeps our blood fresh, available for us to use. So it's something that could be easily overlooked. We may be doing great things by giving the packed red blood cells, but if we give too much packed red blood cells, we lower the 2,3-DPG and cause a shift in the oxyhemoglobin dissociation curve, and we could be overlooking some major things that are contributing to this worsening acidosis by giving the blood. If we give more packed red blood cells, more than a couple of units, we should definitely consider the use of calcium to unlock our 2,3-DPG.
Yeah, and I think that's the big thing. And I think, when you also consider that after a while, that 2,3-DPG molecule actually gets destroyed, and And one of the negative things about blood banks is that the shelf life is, forgive me, I think it's 40. Is it 40 days?
42, yeah.
42 days, something like that. And so they're always going to pull the oldest blood out of the bank, and they're going to give you the oldest blood. Right? Makes sense. I mean, I get that. So you have all this time where all those important elements are destroyed. One of the things that I love about the military is, what does the military do? Right? They've got a walking blood bank. And so instead of giving packed red blood cells, they give whole blood. Right? And I think that's genius. And they don't have this issue to the point of the civilian environment. There's another thing that's really, really kind of on my radar that have kind of become obsessed about, to be honest with you, is the aspect of vasopressin. And I think vasopressin, honestly, is the most underutilized medication. I know it's expensive right now, but when you think about the utility, the application, how safe it is, how powerful it is in not only upper GI bleed, in sepsis, and when you think about the utility of hitting those vasopressin receptors and how powerful those receptors are, one of the things that we have to really understand is that when we give packed red blood cells, not only does that citrate destroy and grab onto the 2,3-DPG to where we can't even utilize the O2 molecule, right? We have a greater affinity now, and our crowbars aren't working. But now it destroys vasopressin. So, our donors will donate this blood, and within hours, actually, of adding the citrate to the packed red blood cells, vasopressin is destroyed. And vasopressin is a very, very important hormone, obviously. So there's a trial going on right now in University of Pennsylvania, and Dr. Carrie Sims is actually running this trial. And what they're doing, the trial is called arginine vasopressin during the early resuscitation of traumatic shock. And what they do is they look at vasopressin. They utilize vasopressin in patients that, if they've been given greater than 6 units of blood product, so it can be any blood product, platelets, FFP, packed red blood cells. So if they've had over 6 units or at that 6-unit mark, they get a tenth of a cardiac dose, so 40 units IV, and then they get a dose of 0.04 units per minute for 48 hours. And they're having amazing results. I've listened to a few podcasts on this where she actually discussed this. And it's really interesting how she actually discovered this. And it's kind of a sad thing. And not to quote it and take too long, but she basically was in her residency working as in a trauma capacity. I don't remember if she's a trauma surgeon, but she may be. And she was in the ICU, and she was dealing with a patient that had massive hemorrhage, and she could not get the blood pressure up. It would not respond. And I don't remember how many units of blood that this patient had received, but it was a massive hemorrhage protocol. And she basically made the decision. She's like, you know what? Vasopressin works in our sepsis patients. I'm going to try some vasopressin. So she hangs some vasopressin. She started her vasopressin at the 0.04 units per minute. And the blood pressure responded. Blood pressure came up, and I think she was able to titrate off other pressors. And her attending the next day basically wasn't happy with her. And I know she said she was, very kind of low. And so he challenged her to find the data. What data do you have to support your treatment, right? And there was really no data. But she kind of saw the utility. And I think that's how this trial started, and they've seen some great positive effects. So I think that's something that I look forward to seeing and identifying. And when you kind of consider that, they've also identified that our stress hormones are depleted, right? And those are essential. Cortisol, and essentially we're sitting there and we're giving packed red blood cells, and we're giving our patients adrenal insufficiency is what we're given. What are your thoughts on that? I mean, if you have any.
I think it's an amazing finding. The use of vasopressin in trauma. For a few years there, the use of pressors of any type in trauma was kind of seen as an abstract idea of not conforming to the current thinking that if trauma patients need blood and they need resuscitation, not pressors. But I have here in front of me an article from 2001 discussing the pathogenesis of vasodilatory shock. So the mechanisms that contribute to vasodilatory shock are present in prolonged hemorrhagic shock. You know, the same things that happen when our plasma catecholamine concentrations are decreased from prolonged hemorrhage. You know, the same things that happen in sepsis, the same things that happen in neurogenic shock, the same things that happen in any type of distributive shock are present and contributing in hemorrhagic shock. And this sounds like the perfect patient.
Yeah.
For that. That's been bleeding for a couple of days, and they're not responding to pressures or fluid resuscitation to any point. That increased capillary permeability is present and contributing in this patient. May not be the case in initial trauma, but someone who's been bleeding for a couple of days, that's powerful.
Well, I think the thing I love about vasopressin is that, you know, just like we know in sepsis, if they're adrenal insufficient, or I should say, I'll correct that, if they're vasopressin depleted, then it's going to work. It will give you a positive blood pressure change. That's the key. Only works if they're vasopressin deficient, and will only improve blood pressure if, again, those vasopressin receptors are uptaking that vasopressin you're given. If they're not vasopressin depleted, it doesn't matter. The body basically absorbs it and it doesn't need it. And there's no after effects. There's no ill effects of giving that administration. So there is never, ever, 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 and I can't stress this enough for you listeners, there's never a time where we shouldn't try it. Now, obviously, I'm thinking more of sepsis, where there's no definitive proven guideline yet of vasopressin use in this setting. But in sepsis, I mean, there's never a reason why. I mean, it should be your second line pressor in every patient. You know, try it. If it works, it works. If it doesn't, it doesn't. You know, there's no reason why. We have a dose range of 0.01 to 0.04 units per minute. Always max it out immediately. Go to 0.04 units because it's not going to cause any problems. And so I think that is a really big point. And mark my words, you know, we're not to change the subject, but when you think about vasopressin, the utility, one of the things that anesthesia does in the OR is they use different medications for push dose pressors, right? We have a big push dose pressor kind of push right now. And it's amazing, traveling around the country doing these review classes, there's EMS agencies. There's state protocols now that have push dose pressors. And there's no clinical data showing the benefit in the pre-hospital environment. Yeah, in the OR, but you talk to an ICU nurse. I mean, you're an ICU nurse. Anesthesia is not going to let a patient die in the OR. They're going to give them a bump of epi or neo. They're going to push them to the OR, out of the OR into the ICU, and 5 minutes later, the patient's going to crash. You know, that's exactly what happens. I mean, for you ICU nurses that are listening, you know darn well what I'm saying. But one of the other push dose pressors that they use, and I've talked to anesthesia about this, I've talked to Dr. Dan Davis, scientific advisor for Mary Methods, about this, and you know, he likes the idea. You know, I think we need to study this, but why not use vasopressin as a push dose pressor instead of epi or neo? It's going to be safer. Doesn't cause any problems. Use 1/10 of the dose. That's what they do in the OR. They'll use 4 units. You know, and so I think that's something that needs to be studied, and pretty cool. One of the things that you pointed out earlier was the aspect of calcium. You said we need to give some calcium in this patient. So kind of talk about how calcium is grabbed onto by that citrate, and how that kind of affects our patients in a negative, if you don't mind.
Yeah, so that in addition to the 2,3-DPG that gets bound to by the citrate, so does your free calcium. The free calcium binds with that citrate, which is the preservative in the packed red blood cells. So in going back to the labs in this case, this young man has a calcium of 6.8. So I can anticipate that the more that I give more packed red blood cells, the more it's going to contribute to that worsening hypocalcemia. And as the citrate binds with the calcium, it's going to cause things like poor cardiac activity, reduced tone, inverse phosphorus levels, and low magnesium. So it's going to worsen this guy's case in the things that we're thinking that we're doing to better him. We're going to be contributing to his acidosis.
Yeah. Yeah, and I fully agree. And this is something that, Scott Weingart has taught for a lot of years. I know he taught this 6-7 years ago when he first started his podcast, the MCREP podcast, and it was something I just grabbed onto and I'll never forget. And I think this is something we often forget. But really, you have a patient in massive hemorrhage in the pre-hospital environment, and they're hemorrhaging out and their blood pressure is low. That should be one of the first things you grab is an ambient calcium gluconate, and you push an ambient calcium gluconate, and that will do wonders for that patient. Right? I mean, we're giving blood in the field, but even them just hemorrhaging out, they're losing free calcium. And so our ability to manage our patients as far as their shock state will be optimized by giving an ambient calcium gluconate. And it's not going to hurt your patients. It will optimize their cardiac contractility, their cardiac output, and their vascular tone, and their ability to actually compensate correctly. And I think that's something that we forget is grab that amp of calcium. Gluconate is always going to be better in the hospital, pre-hospital environment, a little safer. What do you think?
Not to belabor the point about calcium, but a short story about how calcium sticks out to me, how I hope to never forget calcium in the presence of massive transfusion of packed red blood cells. Prior to deployment a couple of years ago, we had some ICU nurses and ER nurses come train with us because they were going to go downrange with us and be a part of the medevac community for that year, and which I thought was a phenomenal idea. We, launched this week-long training exercise where we ran simulated missions and we used high-fidelity simulators. And one of the endpoints, one of the lessons to be learned was just this point, not using component therapy, using just packed red blood cells because that's what we have available to us in the pre-hospital setting. And we know that that's better than lactated ringers, even though lactated ringers is better than normal saline. If we have packed cells, give it. That one of the scenarios was, a guy gets 10 units of packed cells from a forward surgical team. And, in flight, you give another 2 or 3 units of packed cells because you think that he's still bleeding or he's under resuscitated. And the next thing you know, he goes into cardiac arrest. And that was a scenario that we ran over and over again for that week with multiple iterations, multiple people. And it was a discussion that we had over and over and over again. And after we did the after action review, and we talked about that point, and we talked about some of the same things we're talking about here. And it was kind of a gratifying feeling because 6, 8, 9 months later, one of the nurses that partook in that training called me up and she said, "Hey, I got to tell you, I had a patient the other day, picked it up from a forward surgical team, and he got, 20 units of packed red blood cells.
Holy cow.
We gave him another unit and he went into cardiac arrest. I had no idea why. I'm thinking of my H's and T's. I had no idea why. And then you popped into my head when you were yelling at us about calcium, and I pushed an amp of calcium. A couple minutes later, return to spontaneous circulation, and she drops them off to the, combat support hospital with a pulse.
Yeah.
So that's an
awesome story.
That to me, makes calcium stick out in my head. And if I'll probably mess some other things up, but I don't anticipate calcium being one of them.
Yeah, again, an amp calcium gluconate in that patient there's not going to be a bad outcome. That's a positive thing. It should be absolutely 1 or 2 down on your list after airway management, controlling that bleeding, starting the packed red blood cells, getting volume resuscitation going on. But that should be in your tool bag on every trauma patient like that. Fully agree. That kind of segues really cool into the last kind of big section is the lethal trauma triad and really what kills our patients. Obviously, traumatic hemorrhage is what's killing our patients, but are we able to maintain their temperature? And, if they're bleeding out, they're hemorrhaging out, we know that we're not regulating their temperature just based on hemorrhage. We also understand that, blood products, the greatest contributor to hypothermia is room temperature fluids and packed red blood cells, right? Do we warm these before we give them? And I think we've gotten pretty good at warming our fluids, but are they warm to body temperature? I would say no. Are they taken care of properly? And obviously packed red blood cells, if you have the warmers, those warmers are expensive, and I think most flight companies are purchasing those, and I think that's good. But we know that our ability to generate ATP or produce ATP is based on, number one, glucose, secondary to glycogen release from our liver from beta 2 stimulation. And then second is our oxygen. And if we don't have O2 carrying capacity, and then we get into a situation where now we're burning through our glycogen stores because we're shivering, right? That's how we're going to burn through them. We're really kind of spiraling out of control. And I think that is a key thing that I've seen. And again, that's my pet peeve. I have gone to bases in the middle of the summer, and I have been the Nazi. That's my one thing is, where's the aircraft blanket? Where is a warm blanket? I don't care if you live in an ambient environment of 100 degrees. How warm is it in Iraq?
You know, I've been in Afghanistan and but you know, experienced temperatures, you know, greater than 135, 140 degrees.
Yeah.
In a shade.
And there's been studies, and I can't quote the exact study, but there's been studies where they have looked at patients delivered from the field in Afghanistan and Iraq with ambient temperatures at that level, and just short flights, 10, 15, 20 minutes, they're hypothermic.
It's absolutely not uncommon to experience a hypothermic trauma patient in the dead of the summer in an arid desert.
So we got to remember, guys, you're putting them on a backboard. Again, if you're working in an area where you're not backboarding patients, I applaud you. That's good. Not all areas have caught up, right? That just hasn't happened. But you know, if we're putting them on a backboard or and then just putting a thin blanket on them or a sheet on them because we're freaking sweating our butts off, right? In the helicopter, they're not. They're hemorrhaging out. Their ability to generate heat is down, and so that's a big thing. That is where I think we can make a big impact, is taking care of those small little things and helping in their temperature regulation. What does the military do to kind of help prevent that? I mean, I've seen some of your pictures and your videos, and I know every one of them, you were wrapped up in an aircraft kind of mummy blanket.
So, I mean, the lethal triad or triad of death, you know, is comprised of three things: acidosis, coagulopathy, and hypothermia. And to think of those things in its simplest forms, to me, I think when I think of acidosis, how do I correct it? First and foremost, stop the bleeding. Stop the bleeding. Coagulopathy, you know, the use of component therapy, you know, provides clotting factors that have been lost to the patient. So that's how we address, in its most infant forms, the coagulopathy. And hypothermia, it's kind of twofold: warmed fluids and as uncomfortable as it may be to us, applying cabin heat.
Yeah,
you know? That's huge. You know, hypothermia blankets and cabin heat. We may start sweating, but remember, this is not our emergency. It's not about you. You may sweat, but there's a person in front of you that hypothermia could complete this little triad and increase their chances of mortality tenfold.
Well, I think that's interesting. You know, you live in a bubble. We all live in a bubble. And obviously I've flown in this area for the last 8-9 years now. And previously came from Oregon, and we had the same life blankets. And I know you utilize the life blanket, the yellow blanket that's got the inner fleece blanket, and they're pretty warm. I mean, I would assume. But, you know, I was speaking at a conference down in the South area, like, you know, in Georgia, Alabama area, and talking to different flight crews and people that I know. And we were walking around the exhibit area, and I pointed that out, and they had never seen that before. I said, "You don't have these on your aircraft?" They said no. They'd never even heard of them. And it just blows my mind. You know, obviously that's a much warmer area, but I think we again have to remember. I mean, what if even if you took the stance of, we're just going to do it? What if you get on a patient, you know, you have a dementia patient that wanders out and falls in a creek, right? Could be 110 degrees outside, 100% humidity, but we know elderly patients lose their ability to regulate their heat. Now they've just, you know, been laying in a creek. They're hypothermic. How are you going to regulate their temperature? How are you going to start warming without something like that? I'm going to get off my soapbox. But anyway, so when we think about, you hit on the three aspects of the lethal trauma triad. Hemorrhage is a big one. And that hemorrhage is what kind of cascades and leads to the other things, coagulopathy. And I think one interesting point, when we look at that, that leads to acidosis also. Hemorrhage leads to acidosis. And one of the key things I want to focus on is a pH drop from 7.4, which is normal, to 7.0 decreases the coagulation cascade effectiveness by 55 to 70%. That is huge. That is a huge, huge number. So again, it all comes back to our standard BLS. Controlling the hemorrhage, getting it stopped, control that, start replacing our blood volume, and then think about the elements of packed red blood cells. Again, thinking about our vasopressin, right? There's no clinical data right now that supports that, but calcium, as Rakeem said, giving that and having that in your tool bag. One of the things we have to focus on when we think about that pH drop from 7.4 to 7.0 is the shift to the right on the hemoglobin curve. And so we have a lack of delivery of oxygen if we don't have our ability to hold on to oxygen, right? What is our primary storage center for oxygen? It's our hemoglobin. And so if we don't have hemoglobin, we can't carry enough oxygen. And we've talked about this in other podcasts. I'm not going to get into my soapbox on that, but remember that 98% of our oxygen stores are supplied on our hemoglobin, and we utilize those in times of stress. And so that's going to lead to a lactic acidosis. It's going to lead to an overall acidosis. And that's where we get into base deficit as we kind of wrap this podcast up. And so a base deficit, and there's a really cool study that we'll put in the show notes that talks about base deficit and how that kind of is predictive of overall morbidity and mortality. And so when we look at this, base deficit for the initial assessment of trauma patients, a base deficit-based classification of hypovolemic shock developed on data from 16,000 patients, plus 16,305 patients. And I think the key thing is they classified base deficit based on class 1, class 2, class 3, class 4, all the way up to class 5. No, stopped at class 4. Is that right?
Yes,
Yeah,
sir.
Class 4. And so there's associated morbidity and mortality with that. What do you think about that? Can you kind of elaborate on that based on the numbers we have?
Yeah, so the base deficit as an indicator or a predictive indicator in hypovolemic shock, shows a concordant progression in mortality or risk of mortality from stage 1 to stage 4. So, stage 1 is less than a base deficit of less than 2. Stage 2 is 2 to 6, 3 is 6 to 10, and stage 4 is anything greater than 10. Greater than 10% or greater than 10 of a base deficit carries a 51.5% risk of mortality.
That's huge.
Yeah.
What is our patient in our case?
He's
a 9. Negative 9.
Yeah.
Yeah, base deficit of negative 9. So, yeah, he's not doing too hot.
He's on the cusp of a 50-50 chance of whether he lives or die, using base deficit as a predictive value, which carries a huge risk.
Yeah, and I think that the key thing there, and we'll put this in the show notes, is looking at base deficit. You're only going to have this in patients you're going to transfer, right? But one of the interesting things, and I touched on this really quickly as we wrap up this podcast, is when they looked at applying blood or getting blood up for the aircrafts, they looked at a very small subgroup of patients. It was only 23 patients in about a month and a half time, but they were able to trace the patients from the point of pickup all the way to throughout the care, and they partnered with the hospital. And one of the really profound things when you look at patients that were transfused based on patients that were not transfused. So patients that were brought in level 1 trauma, they with scene flight, right? A scene flight patient, level 1 trauma with no transfusion, their arrival base deficit was 9.3. So let's just round that up to 10, right? Or we'll say that that's probably between a 40 and 50% morbidity mortality rate. In those patients that were scene flights that were transfused in transport, their arrival base deficit was 3.3. Now, that was only 23 patients. That was done at the beginning of this year. And, I got to commend Kelly Miller for doing this study. I mean, he did a phenomenal job, and he really looked at a lot of endpoints. He looked at lactate. There was a huge reduction in lactate. He looked at hemoglobin and hematocrit. There was a big improvement in regards to that. He looked at trauma score. He looked at lots of different things. And so I think the key thing here is just based on a small sample size like that, that is a huge reduction. I mean, when you look at, you said that 51%. I mean, if you now compare that to 3.3, what class is that? That's going to be a class
2.
Mm-hmm. Yeah, and so that's a big reduction. So I think that kind of goes back to exactly what you said. It's early blood control, hemorrhage control, I should say, and transfusion. Yeah.
Yeah, absolutely. I think we've set the gold standard by putting packed red blood cells on aircraft, and then the next thing is FFP.
Absolutely. Yeah. So I think, the key thing here is focusing in on the underlying issue. Mm-hmm. Don't get tunnel vision. Realize that, number one, you've got to stop the bleeding. When we look at our patient and we kind of identify this, we said that just based on his base deficit, he had an almost 50% mortality risk. You also look at his shock index of 1.4. That matches. We know based on some kind of early clinical, looking at some data from different patient subsets, when you have an end tidal less than 25 and a systolic blood pressure less than 80, that is an ominous sign as well. That's an impending arrest. And it's funny when we think about one of our colleagues that we both know and work with. I don't work with him anymore, but I remember it was his first flight, and I was precepting him. It was Kyle, good old Kyle, and real sad story. But I started seeing this end tidal trend down from 35, and it went to 32, 31, and I didn't say anything. And it got down to 28, and I looked over at him and I said, "This patient's about to arrest. Get ready." And he looked at me with this puzzled look, like I was crazy. And it trickled down to 25, 23, and boop, change. And we didn't discuss it at that point, but he got an introduction in compressions in a tight helicopter. And I think that's the key thing. This end tidal of 22, we talked about the 3 Ps. To focus on perfusion, make sure they have a pulse, and what's their pH status. And so we were able to get all that information. What are your thoughts on, kind of in summary, applying what we've talked about to his labs?
So, I mean, on a scene flight setting, on a pre-hospital setting, you're not going to have those labs. So I think my take-home point to the listeners is a use of predictive indicators. That is one thing that I appreciate, very much so appreciated from my time in service with the military, was catering or applying advanced concepts in ways that are easy to remember. Using those things that we learned, that we talk about today, and thinking about them in the most simplest way possible. So indicators, right, for transfusion, if I have blood. One, did they have a mechanism of injury? Do they have a gunshot wound to the chest? Do they have a blast injury? Is it a car wreck with, some massive intrusion, or another occupant dies? And what is my systolic blood pressure? Is it less than 110? Is my heart rate, my tachycardic? Do I have an obvious bleed? Those are all indicators, things that we can use to say, hey, what's the chances of this guy bleeding, right? Or being bleeding or needing blood? And using all of this information to determine whether or not it is a good idea to transfuse these patients. And that's the take home point that I think that some of the studies very explicitly demonstrate to you that you're going to put in the show notes. And I think one of them actually says it, that to use these techniques as predictive values as to when to transfuse in the absence of laboratory analysis.
Yeah. So do you think, where do you think TXA falls into this?
I think TXA is huge in this. Understanding TXA is huge. So while TXA may not contribute to the resuscitation in a sense of providing oxygen carrying capacity, understanding that is, man-made lysine that says to clots, formed clots, please don't break down. You're helping me out, and I don't want you to leave just yet. That's what TXA is saying to you, and understanding how that helps the patient, in combination with permissive hypotension, not raising that blood pressure for the sake of making numbers look pretty and potentially blowing those formed clots. Those two things are essential in the treatment of trauma patients, pre-hospital and intra-hospital.
Yeah, I completely agree, and I think what are your endpoints on TXA administration?
TXA administration.
If you have endpoints, I guess when would you employ this?
When would I employ this? The same. If I have a reason to give blood, I should give TXA. There's conversations about use of the tag and specifically testing the clotting cascade and where people are deficient. That's not something that's for us pre-hospital providers. If you got TXA and if you think I would give blood, give TXA. Give that gram bolus in the first 10 minutes. Because if you bust that 3-hour window of giving the TXA, then it's no longer applicable. We can't give it 3 hours after injury. And that 3-hour injury seems to be a landmark that keeps repeating itself. If we give blood products within 3 hours, we increase the patient's chance of survival, of recovering from massive hemorrhage.
Yeah. I think, to kind of hit on the high points, indications for TXA, got to be an adult patient greater than 18, systolic blood pressure less than 90, pulse rate greater than 110. They can be tachypnic greater than 24. You don't have to have all these things. So again, using a high index of suspicion, really the same indicators of giving blood, right? And so that 90 systolic is kind of that point. And I know for the study that I talked about where we saw the big improvement in base deficit, I think they used 2 systolic blood pressures less than 90 as their indicator to start blood. And so, I think that starting blood early is key. And as we talked about before in this patient, getting blood on board and identifying the labs, identifying the calcium was low, and giving an amp of calcium gluconate. Remember, calcium gluconate is not as potent as calcium chloride. It takes 3 amps of gluconate to equal 1 amp of calcium chloride, and it's much safer to give in just your peripheral IV lines rather than chloride. So when we kind of look at this from a summary standpoint, stop the bleeding, right?
Absolutely.
Stop the bleeding. Understand our volume, right? Know what you're giving. Don't just throw normal saline. For you out there that have agencies, utilize the FlightBridgeED podcast to make change. Don't just go out and practice outside your guidelines. And I say that for in all kindness, but you take this to your medical directors. Think about, you should be utilizing both fluids. In burn patients, you don't give normal saline, you give LR. So you should be carrying that on your ambulance. Identifying your airway management patients, like you said, predictive indicators. And so what can you take home from what we've talked about, your experience as far as airway management? What is our big thing that we do wrong in those patients?
Resuscitate. Begin the resuscitation. You can, prior to pushing medications that are going to compromise the patient from a circulatory standpoint, you can begin the resuscitation and improve your chances of success, improve or decrease the chances that the patient is going to arrest in the peri-intubation period by beginning the resuscitation, balanced resuscitation.
Yeah, I concur 100%. Slow yourself down. Utilize your team around you. Remember, going through paramedic school, one of the biggest things I remember my preceptor that I worked with throughout my whole internship was, it wasn't so much for me the application of the medicine. I felt like that was there. But I remember he focused a lot on making sure I understood the power of the team. And it's all about delegation, right? Utilizing every person in that team. And so you have a lot of people, especially, anytime you have a helicopter around, people want to help. You got a lot of people. So you got to utilize those people. Utilize the power and the energy that's in that ambulance or that room. Then we got to focus on permissive hypotension, right? We need a map of 65 in just a massive hemorrhage patient, traumatic injury, blunt force trauma, but we have to also consider traumatic brain injuries associated with those patients, and those patients need a MAP a minimum of 85. So I think 90 would be safe to say in a traumatic brain injury patient, achieve a MAP at 90. And then heat loss, heat loss, heat loss, heat loss, heat loss. Remember, you're going to be losing heat without you even realizing it. And I think, Rakeem, you've really hit on a lot of high points as far as military application. And if it happens at 130-degree ambient temperature, what do you think it's going to do here? Right? I mean,
what's going to happen after we give blood that we haven't warmed?
Yeah, I agree. So heat loss drives our trauma triad of death. It kind of, adds to the decompensation of our patients. And then we got to warm them. We've got to give them enough volume. Don't over volume resuscitate them. Think about blood if you have that ability, or if you only carry FFP, that's great too, right? We need our clotting factors. And remember, our prompt trial showed a benefit of giving packed red blood cells, or I should say FFP and platelets in our patients, right? Replacing those clotting factors that we've lost. So I think we've hit on everything. Is there anything you want to say or anything you want to add before we wrap this up?
Yeah, I'd say to the listeners, understand that every day that goes by is an opportunity that you have to get better than you were the day before.
Absolutely.
So understand that there's always going to be somebody bigger, faster, stronger, and smarter. So work towards that next goal. Set goals and achieve them, and work every day towards them.
Yeah, absolutely. For those of you out there, we do this a lot on the Second Shift podcast, kind of give shout outs. And, I want to kind of dedicate this to all the soldiers out there in all branches of the military. Want to send a special shout out to the 3rd Special Forces Group. Got an email from Daniel Mills, said that they were fans of the podcast, and so we really appreciate that. Would love to meet you someday. So email me, and maybe we could work something out. And to all the soldiers out there that have dedicated their lives. I mean, I'm very patriotic. Did a short stint in the military back in 91. Not many people know that, but can't ever say I was deployed. We've talked about that. I don't really consider myself a veteran even. So my hat's off to you for serving your country as long as you did.
Soldier a day is a veteran for life. So doesn't matter the length of service. Everybody signed on the dotted line and wrote a blank check in the name of the Constitution. So thank you for your service.
It wasn't much. So on behalf of Rakeem, I just want to say thank you. And if you have any questions, any comments, if you're looking for a review course, please check out the website. We have review courses booked out all the way into October. Have our yearly review course we're holding in Las Vegas in October. So if you're wanting that trip to Vegas, want a tax write-off, check it out. And again, if you're looking for a review course, you want something in your area, please reach out to me and we will make that happen. And until next time, we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education. For more, visit FlightBridgeED.com.